So thank you all so much for joining us today at this Healthy Women Community Talk presented by the UW Department of OBGYN. This is one of a series of free talks that we offer on a variety of women's health topics. We have one more this year that I would be remiss not to name drop. So on November 6th, we will have some of our advanced pelvic surgeons talking about pelvic floor disorders at the Goodman Community Center. If you'd like to learn more about it, we have materials on that back table. And since you're here tonight to learn about ovarian cancer, so presumably you've got some interest in gynecologic cancers, I also have to name drop Sparkle of Hope. Sparkle of Hope is coming up on September 20th, about 10 days away. It's a wonderful gala, dinner, drinks, silent auction. Everything we do raises funds for gynecologic cancer research in our department and at Carbone. So we also have invites and information on the back table for that. Okay. A couple quick housekeeping items, which will also explain this super awkward microphone situation. In addition to all of you who have joined us in the room, and again, thank you for being here, we do have many people watching online with us tonight. So this is mainly to make sure that they can hear what's happening with us, and this will become important again later when we have question time. So we'll save questions for the end, and we will bring this mic stand up to about the middle of the room. So if you can bring your question to the mic so that our online viewers can hear what you've asked, and then Dr. Barroilhet will very capably answer it. Okay. We would like your feedback. You were all given a survey to fill out when you checked in at registration. Our webinar attendees should have gotten the link to the survey as well, so please just let us know what you thought, what else you'd like to learn about. And now I can introduce our amazing speaker. So I'm very excited to introduce Dr. Lisa Barroilhet. Dr. Barroilhet is the Dolores A. Buechler Faculty Fellow in Gynecologic Oncology. She's an associate professor in our Department of Obstetrics and Gynecology. She did an awesome residency at University of North Carolina, Chapel Hill, followed by a Gyn-Onc fellowship at Brigham and Women's in Boston, and joined us in 2012, where we've been super jazzed about it ever since. She specializes in a lot of things, including minimally invasive surgery, ovarian cancer detection and prevention, and survivorship issues. And her primary interest for research is drug development for treating and preventing ovarian cancer. She is absolutely our go-to expert on ovarian cancer, which is why she is here tonight to talk to us. So please help me welcome Dr. Barroilhet.
Thanks. Wow. Thanks, Jackie. I've been told that this microphone here is important. So I like to be free range, but I've been told this needs to happen. So do tell me if you can't hear me at any point. I usually encourage questions during the talk, but I understand that's unfair to our people watching remotely. Shout out to you guys. But if there is something I'm saying that's technical or you don't understand and you think would help other audience members, please raise your hand so we can address it in real time. I would hate for a concept to be lost. This is something I am very, very passionate about. I spend a lot of my time taking care of women who either think or know that they have a hereditary cancer syndrome, meaning a genetic risk that puts them at a higher chance for getting ovarian cancer. Obviously, I meet a lot of these women very young. They haven't had their children yet. They have a lot of very scary decisions ahead of them, and I would dream of a day where we can make this easier for patients. So that is the heart of what I'm talking about, but there's a lot of science to this talk as well, and that it's always hard to strike the right balance. So we're going to talk about DNA, we are going to talk about chromosomes, but it's going to be okay. And we'll also talk about what this actually means and how this affects, I know, people in this room or people that you love or care about. There is a handout in the back. I'm guessing many of you got it. It's a very basic primer on what a gene is. So I'm going to use that word a ton. And genes are basically instruction manuals, essentially. So it's what tells our body and our cells how to function, what to do with the proteins and the enzymes and all the other pathways that help our body metabolize energy and use food effectively and breathe air and turn oxygen into CO2. All that stuff happens at a cellular level, but genes control it. So when we talk about a genetic error or a genetic mutation, what we're saying is something has gone wrong on a genetic level that is screwing up how the cells function day to day. There's more information on the handout, but I thought that might be helpful since all of us took high school science varying amounts of time ago, and a lot has changed in the last 20 years. So let's do this. I don't have any disclosures, and why that's important, it means there's no drug company that's telling me what to say. I am gonna mention some specific medications during this talk that are FDA approved for ovarian cancer and have to do particularly with hereditary ovarian cancer. Nobody has told me that I need to say anything about these medications. I say it because I think they're important and exciting options. So we'll talk a little bit about the realities of ovarian cancer, what it looks like, how it presents, signs and symptoms. We'll talk about populations that are at high risk for developing ovarian cancer. BRCA or BRCA mutations are probably the ones that the people in this room are most familiar with, but there's others. Lynch syndrome's another example, and we'll talk about more. We'll talk about who should be screened, who should be tested, what risk reduction options are available once someone is identified as being at a high risk for developing ovarian cancer. And if we have time, we'll talk a little bit about precision medicine. This is another area I'm very passionate about, but something that's really been getting a lot of attention appropriately is targeted medications, or the idea that you can look at someone's genes or someone's cancer and look at the particular proteins that are behaving badly in that human and actually target a therapy for them. We have a long way to go, but we've also come a long way, and that's something that's really exciting to share with the community. I'll probably talk about my research for less than 2 minutes, but I can't stand in front of a crowd like this and not tell you guys what I do, because it's why I get up in the morning. Ovarian cancer, it's a disease that we consider of postmenopausal women most typically. So you can see here the average age, the median age is about 63 at diagnosis. It's a bell curve like most things. Do I have a laser? Yes, it's just dim, like most things. So you're going to see a lot of diagnoses in the 55 to 65 range, but you do see, unfortunately, you see very young women diagnosed. We do see women up to in their 90s diagnosed with ovarian cancer. We know that the signs and symptoms of ovarian cancer are particularly slippery and troublesome and make it hard to diagnose. I've listed some of them here. And these are things that any of us could feel after a day at the Wisconsin State Fair. So it can become very confusing. Is this a gastrointestinal virus? Is this a sign of early cancer? What I talk to women about, particularly women at high risk, is thinking about a change from normal, persistent symptoms that are very different from their baseline. So something that abdominal bloating, early satiety, meaning you take a few bites of food and feel full, dyspepsia or indigestion, things that you don't typically have and are now having more than 12 times a month, you should be evaluated for that. This is hard. And a lot of times, the frustrating piece is women appropriately are describing gastrointestinal symptoms. And so people go down this, irritable bowel syndrome, constipation, all these other things that are real, and very real diagnoses, but it takes a while to get to a pelvic exam or hey, maybe this is gynecologic. So I never give a talk to the community without saying this, because a lot of people in this room are female. Many of you have ovaries. If not, you know someone with ovaries. So this is important to keep in mind. And if you're hearing these symptoms or experiencing these symptoms, I think it's important to let your doctor know, and in the context of, hey, could this be gynecologic? So when we talked about ovarian cancer risk factors, there's some things that put you at higher risk, some things that actually reduce your risk. Not surprisingly, if you have a family history of ovarian cancer, that does increase your risk. We would say it would increase your risk between 5 and 7 times that of the general population. BRCA mutations and Lynch syndrome, which we're going to talk a whole bunch about, can increase your risk like 30 times that of the general population, so 30 to 40% overall. So this can really make a tremendous difference in how likely you are to develop one of these diseases. We do know a little bit less about this, but we do know that people who have struggled with infertility and have never been pregnant have a slightly higher risk of ovarian cancer than those who don't. And late menopause and early menarche, that tells us how many periods you've had over your lifetime. So if you started your periods early and stopped your periods late, that probably means you've ovulated more over your lifetime. And that also goes into infertility and not having kiddos. Nulliparity means you've never been pregnant. So that's all time that you can be ovulating. When we talk about genes and DNA damage and protein signaling going awry, the more you ovulate, we think, the more opportunity that DNA in those cute little oocytes, those little eggs, have to make a mistake. So when we think of things that are protective against ovarian cancer, we think about things that prevent ovulation from happening. So guess what? Having a lot of kids, you're not ovulating when you're pregnant. So that's a good way to decrease the number of times you ovulate. Using birth control pills. It's an anovulatory form of birth control. Now, other birth controls can cause anovulation. The NuvaRing, the patch, other estrogen, usually it's estrogen and progesterone containing formulas. But there's some birth controls that are excellent and do not suppress ovulation. So it's really important to, if you have risk in your family, or if this is something important to you, that you're really talking to your physician about the type of birth control you use. It can make a tremendous difference. A woman who's been on birth control for between 4 and 8 years has reduced her ovarian cancer risk by 50%. That is very powerful. And a lot of us have done this. For a while, that was the only game in town for birth control, right? So a lot of people have been on the pill, and many people have been on it for decades. So that is something that I think there's other side effects. It's not right for everyone. But that is something we should sing the praises for. That is a really nice accidental benefit. So this is also important. I think we spend a lot of time thinking about hereditary syndromes. BRCA, BRCA has gotten a ton of attention. Angelina Jolie, I think, was one of the first celebrities who acknowledged having that diagnosis and also spoke openly about risk reduction surgeries that she had chose to have. Yeah, I think that's good grammar, that she had undergone. And I think she drew a ton of attention to this. And not surprisingly, after she revealed this, we saw tons and tons of women coming to our clinic saying, I want to be tested. Super reasonable. But please remember, 90% of all ovarian cancers have nothing to do with hereditary genes. They have nothing to do with what was going on with your mother, your father, your aunt, your uncle, your siblings. Cancer, the vast majority of cancers, happen because of bad luck. I wish I could explain, because you want to understand why this is happening to people. And I wish we had better explanations, but it's important to recognize that over time, our genes can have what we call somatic mutations, which happen from environmental impact. It happens just from aging. So all the same things that happen that make genes misfire can just happen because you've been alive another decade. So please remember that. There are many people with ovarian cancer who do not have any hereditary risk and whose family members are not at risk. It is important, though, to find those who are. So when we talk about hereditary ovarian cancer, we're really talking about BRCA 1 and 2. Those are the best 2 genes, and there's slightly less of the pie now because we found others. We keep finding more the more we look, but they really are between 80 to 90% of familial ovarian cancer. So not surprisingly, I'm sorry I keep hitting that microphone. Not surprisingly, we'll spend a lot of time talking about that. But there are others, and they deserve some attention as well. So who gets tested? When someone walks in my office and says, I would like to be tested for BRCA, I don't just say yes. And there are reasons for that. You want to better understand how at risk that person is, and you want to make sure you're actually testing them for the right things. Because sometimes patients say that, and I get into their family history, and it's a lot of things. It's often a lot of cancer, but it's a lot of non-gynecologic cancers. It's a lot of things that might be familial but have nothing to do with BRCA. So it's actually important to look at the family history patterns to decide who gets screened. I will say this, right now the recommendations, and these are from the Society of GYN Oncology, say if you have an ovarian cancer diagnosis, you should undergo genetic counseling and testing. So that is a pretty wide swath of patients I see, and I appreciate that they made that simple. They said, listen, it's only going to be 10 to 15% of you, but that is enough. And that impacts not only your family members, but it impacts your breast health. Even if you've been diagnosed with ovarian cancer, right, you're at risk for other cancers, and it can impact your family members. And those are all good reasons to get tested. So right now, that is the current recommendation. I don't anticipate that changing. So if you or someone you love has an ovarian cancer diagnosis and hasn't explored the idea of genetic counseling, I would strongly recommend you consider that. Some women who I offer genetic testing to say, hey, I really don't want that. I really don't have any family members with cancer. It just doesn't seem to make sense. We do see that almost a third of women who describe that still can have a third of women who have hereditary cancers really don't describe a strong family history. And the reality is, especially with ovarian cancer, it's almost never what's on the death certificate. It might be cancer, but the gynecologic organs are like this big unknown. And if I'm just going to be a little bit gender bias, but if it's 1960 and it's the guy filling out your death certificate, they weren't thinking about your ovaries. I'm just being honest, right? That's not the headspace that people were thinking about metastatic cancer. So it's possible that a grandparent or an aunt or someone did die of ovarian cancer and you just didn't know it. Also, many of us are estranged from parts of our family, and we might not know what happened to Aunt Sue or a cousin. So I think the fact that patients aren't describing a family history is because sometimes we don't know all the details. And it's also important to remember ovarian cancer, even in hereditary lineage, even when it's passed down in a family, it still tends to happen closer to menopause. So people think that if you have a hereditary cancer, you're going to get it really young. Those are going to be the patients we see in their 20s or 30s. That's not the case. You could be a 70-year-old with a new ovarian cancer diagnosis, and we could still find a genetic mutation. So those are the two myths that I commonly dispel when patients question if genetic testing makes sense for them. So this is not an inclusive list, but if someone did just walk into my office without a cancer diagnosis saying, hey, am I someone who should maybe consider BRCA testing? These are the things I would start to ask about. Their own personal cancer history and the cancer history, most tellingly, of their first-degree relatives. So first-degree relatives is someone that shares half of your DNA. Your mother, your father, your siblings, your children. So that's where we start. Yes, cousins, aunts, uncles, that is important, but when you think about genetic risk, you really want to look at the people in your family whose DNA is the closest to yours. So that's where you start those questions. And what you're looking for is early breast cancer diagnoses. So breast cancer diagnoses well before menopause, so 45 is a typical cutoff. If you really can't find much family history, you may extend that to 50. Ashkenazi Jewish heritage is an important question. We do see BRCA mutations more commonly in that population, and it is important to understand if that's part of someone's genetic makeup. It could change their risk. And then someone who has a family member or a personal history of 2 different breast cancers, so had a breast cancer in one breast and then a second breast cancer in the other, diagnosed after a period of time. So not surprisingly, the family history questions are very similar. And if you have a known family member with BRCA, that is a good reason to be tested. So if someone who you have shared DNA with has tested positive, it's always worth going to talk to a genetic counselor to see who in the family is positive and if it could have been passed to you. Male breast cancer. I want to mention that. Male breast cancer is almost always associated with BRCA. I'm sure there's people in this room who've never seen it. I've never seen it. It's not common. But if you do have a male breast cancer in your family, almost certainly there's something genetic going on, and that should really prompt a genetic inquiry. This is busy, but we're going to talk a little bit about it. The first thing, I do want to say something first, which is I say genetic counseling and genetic testing, genetic counseling, genetic testing. Those two things are actually different, but in my mind, they should go together. So a genetic counselor is someone who has a master's degree, who spent 2 years, including clinical training, learning how to take a detailed family history. They've also learned so many genetic syndromes and things that can be passed down from generation to generation related to cancer and related to non-cancerous syndromes, Marfan's disease, Huntington's. There's a million examples. And so when they take a family history, they don't just have their cancer hats on. They actually look at other things that are happening in family lineage and do a really good job of being thoughtful about what genes they're testing for. If I see a patient, I'm a gynecologist. Guess what I'm going to think about? Ovarian cancer, maybe breast cancer. That's what I think about. These are the people I see. So I'm going to test you for the genes I know. A genetic counselor is going to be more thoughtful and really think about a full panel of testing that could potentially be helpful. Or if you're not the best person to be tested, identifying who in your family would be and helping you, helping you if you're not comfortable making contact with them. So I actually think genetic counselors have a ton to add to this, and how I start this process with my patients is referring them to a genetic counselor. There are 5 excellent ones at the Carbone Cancer Center who do primarily genetic counseling. We have others in our organization that do other types. Obviously, we have fantastic prenatal genetic counselors. They can serve a lot of different roles. But to me, just ordering testing, while in some cases might be the right thing to do, typically, I try and engage in a genetic counselor in that process, and I think that they're very valuable. All right, so what is BRCA? I've been talking about it now for 10 minutes. So BRCA, it's not surprisingly, it is a gene, and there's two of them, BRCA1, BRCA2. They're what we call tumor suppressor genes. And tumor suppressor genes are like police. It is their job to make sure the DNA is replicating correctly. If something is wrong, they swoop down. There's this little complex of little BRCA friends that swoop onto the DNA and say, no, 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 you didn't get your nucleotides lined up right, you're messing up, and they will fix it. When BRCA doesn't work right, those police people can't do their job, and the whole process falls apart. So the specific thing that they're in charge of is DNA double-strand break repair. You don't really need to know that, but do remember it's the DNA replication part of this that's important. And that becomes important when we think about the targeted therapies that can really be effective for these patients. So it's not just ovarian cancer. Breast cancer, obviously very common. So BRCA1 patients will have up to a 70% lifetime risk of developing breast cancer. Ovarian cancer, 60% is pretty high in the US. We usually quote closer to 40%, but in some of those Ashkenazi Jewish populations, it is that high. Uterine cancer, a small but real increased risk from that of the general population. And BRCA2, again, a very real breast cancer risk. That male breast cancer tends to be with BRCA2. And ovarian cancer, not quite as high a risk as BRCA1, but still very elevated. In the general population, your risk of ovarian cancer, all comers, is about 1%. So you can see 10, 20, 30 times that of the general population. So this is important in terms of what's recommended for patients with BRCA1 and BRCA2, and that's the timing of ovarian cancer. I mentioned that most patients, even with BRCA mutations, don't get cancer young. That's true. Really, your risk, if you round it at age 30, is still less than half a percentile. But what starts to happen as you get into your 40s is that you see this BRCA1 percentage of patients diagnosed with ovarian cancer really jump between 40 and 50. Whereas for BRCA2, it's pretty stable, and it's after 50 where we start to see that increase. So this becomes why the recommendation for BRCA1 women is earlier ovarian removal than BRCA2. So really the recommendation that we'll go into in more detail for BRCA1 patients is to think about the ovaries and fallopian tubes being removed before the age of 40. For BRCA2, closer to 45. Now, ovaries are, it's hard to say this, but they are in general our friends, right? They're great for procreating, that's cool, but estrogen's good for us, and we are supposed to keep it around for our bones and our heart and all those other things close to the age of 50. The average age of menopause is 51. So a dance that I play with these patients is how long can we keep your ovaries in and keep you safe? And that is a very, very hard dance because a lot of these women have lost a loved one to ovarian cancer. They are terrified. They should be. It is scary. So thinking about the timing of this to make sure the women have reached their reproductive goals and aren't going into menopause too prematurely. It's hard. It's hard to get it perfect. So let me mention another hereditary cancer syndrome that doesn't get as much attention as BRCA, but absolutely can increase your risk of gynecologic cancer. And it's called HNPCC. Most people call it Lynch because it's a lot easier to say, but it's hereditary non-polyposis colorectal carcinoma. And as you might guess from that very long name, is that it actually increases colon cancer risk too. Similar story, we're not going to get into microsatellite instability and all of this craziness, but similar story. These proteins are part of these mismatch repair genes. And it's the same idea. Instead of the DNA double-strand break that BRCA is in charge of, it's supposed to help us get our nucleotides in line. And there's these areas of the gene where there's a lot of repeats of nucleotides, and those love to get screwed up. So if your mismatch repair proteins, and these are just different examples of them, aren't working correctly, and that's what Lynch syndrome is, it's another opportunity for DNA error to occur and for the proteins to be coded incorrectly. So Lynch has a lot of cancers associated with it. I mentioned colorectal cancer. This is a lady, this is a guy. And I want to point out that colorectal cancer is really high in men, 80%. In general, men get studied first. They figured out in women that the colon cancer risk is actually quite a bit lower. And it's uterine cancer that is often the presenting cancer. Up to 60% of women will get a uterine cancer with Lynch syndrome. But I got to point out here, ovarian cancer, 10%. as high as 15% in some studies. So again, 10 times higher than the general population. And for decades, all anyone was talking about is colon cancer. So it took us a long time to figure this out. And now we know that these women who are affected by Lynch, it's not just the colon they need to think of. And colonoscopies, I'm sure some people in this room have had them. No one would sign up for those recreationally, but they actually work. And if you know your colon cancer risk, you'll actually get your colonoscopy and you're very likely to find polyps and you can really prevent cancer. We don't have such luxuries with ovarian cancer, which we'll talk more about. So we really need to make sure we're talking to these women and saying, hey, yes, your colonoscopy, but what are we also going to be doing to keep you safe from a gyn cancer standpoint? And there's other cancers, stomach, biliary tract, which is near the liver and bile duct. So there's other places. Lynch syndrome's kind of mean in that it can do a lot of different things. But it is, you can test for it, you can screen for it. And if anyone in this room who was breathing relief because they're like, oh, I don't have a lot of breast cancer and ovarian cancer in my family, there's a lot of colon cancer in your family, I would just bring this to your attention. Colon and uterine cancers. There's a whole list of other genes. We are not going to get into them. I listed some on this glorious sheet that you have as well. The point of this slide is just to tell you that it seems like every week we're identifying a new gene that has an elevated cancer risk. So the more we look for this, the more we're finding. And because more people are getting genetic testing, which is great, the more we're learning about genes that are associated with different types of cancer. So it's really great to understand this better. It's really daunting to recognize that there's so many things that could potentially be linked to increased risk. In general, none of these have been found to be as common or as harmful as BRCA. Most of these, from an ovarian cancer standpoint, incur between a 5 and 10% lifetime risk, many of them less than 5%. So it is elevated and certainly worth talking about, but it's much less likely to result in early ovarian removal at younger ages. So this is important to know. What happens if you get genetic testing? What happens in your medical record? What happens to life insurance? What happens to health insurance? The good news is, so far, and I think the fact that this has been stable from a federal government standpoint says something, but no one has ever tried to touch this. And that if you have a genetic disease or genetic disposition to developing disease, you cannot be denied coverage or be charged an increased premium. And that's federal legislation. We also, as part of the HIPAA Act, says that genetic information in the absence of a current diagnosis is not a pre-existing condition. If you already have a breast cancer, yes, that can be considered a pre-existing condition, but the genetic component of that can't be. So I have not had problems with my patients who are tested and test positive have downstream effects that were negative in terms of health insurance coverage. So I think that's important. I can very much understand that being part of the reluctance to be tested. I do want to speak about commercially available testing. 23andMe is probably the most famous. This is something you can order online. They send a kit to your house. You actually have to spit into a cup. They can get DNA from saliva, which is kind of cool and kind of gross. It's a lot of spit. So if you ever do this, drink a lot of water first. I just want to warn you about its limitations, and I'll speak in the context of BRCA. It does test for one mutation in BRCA1 and one mutation in BRCA2. There are about 15 known mutations in each of them. So one could imagine getting tested and saying, my test was negative. I have this terrible family history, but my test was negative. Cracking open a bottle of champagne and never thinking about it again. That's just not the reality. If you want to do this for fun, fine. But please understand this is limited. This does not come with the wisdom of a genetic counselor. It does not mean that there aren't cancer genes that you could be at risk for. So truly, if someone's bored on a January night and wants to do this, great. That's fine. But if you have a big time family history, please go through, I would talk to your physician, go through the normal channels, see a counselor, make sure you're actually being tested for the things you're genuinely at risk for. Okay, so let's say you are tested and the test is positive. What do we do? How do we screen for cancers? How do we prevent cancers? And who and when is surgery part of the conversation? A lot of this could be focused on breast cancer. There's a lot of breast cancer screening available. There's some chemo prevention for breast cancer. That's great. I'm not going to focus much on that. I'll touch on a couple things. but I do want to talk a lot about ovaries. I'll just mention breast health in BRCA patients. I don't know what breast awareness is. It sounds like something actually that like teenage boys would do really well. But I think what they're trying to say is you should probably be aware of new lumps, bumps, skin changes. It's probably something all of us should do. And then they do start clinical breast exams every 6 to 12 months at age 25. Breast MRIs are actually what's used in younger women primarily. Mammograms don't work well when breast tissue is very dense. Breast tissue is the most dense. The younger you kind of in the teens and 20s, so mammogram just isn't as effective. So they will start with MRI screening once a year between 25 and 29, and then alternate every 6 months, either an MRI or mammogram, up until the age of 75. Now, many women will have elected to get their breast tissue removed or have a breast cancer diagnosis before that time. But that gives you a sense of can you imagine the number of mammograms that you would get in that time frame? I mean, it's wonderful that there's screening, but let us acknowledge the burden that this is placing on this patient. This is a lot of doctor's visits. This is a lot of mammograms are uncomfortable. MRIs take a while. If you're claustrophobic, they're really challenging. This is a lot to ask of patients. So from a Lynch standpoint, I just want to mention a couple things. You're going to get a ton of colonoscopies, and they're going to start young because colon cancers in Lynch families do start at younger ages. You're also going to start getting endometrial or uterine biopsies by age 35. I mentioned that uterine cancer is very elevated in this population, up to a 40 to 60% lifetime risk. So they're going to recommend a biopsy, and it's wonderful that the uterus is actually accessible to the outside world. This is not comfortable. This is, again, not what you'd sign up for recreationally. But the ovaries can't be biopsied. We can't get to them. The uterus is actually accessible in an office setting. So a biopsy is a very reasonable way to approach screening. Keeping a menstrual calendar. So I will have these patients actually track their periods. And it turns out that people who are cycling normally and then report spotting between their cycles or have drastic changes in their cycles, that the positive predictive value of that biopsy goes up. If you're having a symptom to go with that biopsy, not surprisingly, you're more likely to be biopsying someone at the right time. So fortunately, in the age of smartphones, menstrual calendars are readily available as apps and work very well. Jackie, is there something? I'm sensing anxiety. Tell me what you need. Okay. I felt like there was an AV something. Okay. You're good? Oh, the sun. That is not an AV. Yeah, that's a good one. I can't fix that. Nature's AV. I'm sorry. Those of you in the sun, you look really nice. I just want you to know that. Lily, yeah, nice glow. Yeah, okay. Thank you. I actually thought there was a crisis. So what are we doing about our ovaries? You eat BRCA gene, we know Lynch gene, we know there's an increased risk. Ovaries are in your body. What can we do? So the NIH and the NCCN, these are national organizations filled with smart people. What they will tell you to do is get a CA-125, which is a blood test. CA-125 is a protein. It's called a tumor antigen, but it's a protein that's shed by ovarian cancer. It's also made by many other things. So it is not a perfect test. And I have patients who have terrible ovarian cancers and a normal CA-125. I have women with endometriosis or other benign gynecologic conditions that have a very elevated CA-125. So some limitations to what you can do with this test, but it's not nothing. And a TVUS means a transvaginal ultrasound. So that is their best imaging study we have to look at the ovaries in real time. As you can imagine, again, something a little uncomfortable. And the recommendation right now is every 6 months. And the recommendation for timing is to start between 30 and 35. So this is, again, asking a lot of our patients. But the return on investment here, unfortunately, is quite a bit lower than with our breast cancer screening. MRIs and mammograms work. We have data saying, hey, if you are a BRCA patient or high risk for breast cancer, and you are doing your mammograms and MRIs, awesome. We are much more likely to catch your cancer early, to see it when it's smaller, and be able to treat you effectively. I cannot say that to my patients with ovarian cancer. I have 0 studies that say that when I do this to patients, when I put them through this, that they are less likely to die of ovarian cancer. And that is a miserable statistic that absolutely has to be changed. To me, this is mission critical. If I want to cure ovarian cancer, I know how to. I just need to find it at stage 1. I cure stage 1 ovarian cancer every time I see it. If it's confined to the ovary, guess what I do? I put that ovary in a bucket, right? You might need some chemo, but we got you. If it's that cancer's all over the place, it's a lot harder. And that's the problem, is even when we're doing this screening religiously, ovarian cancer develops quickly and spreads quickly. It likes the whole abdominal cavity. It doesn't like to stay put like breast cancer does. And so it makes it a whole lot harder to screen for. So yes, these are the recommendations. Yes, I do offer this and do this to my patients, but this has been studied and still is very lacking in terms of efficacy. I'm going to point out the biggest study that's trying to answer this question. It was published in the Journal of Clinical Oncology. It's a big journal, good journal, in March of 2017. Big trial in the UK. Good place to do this study because of the National Health Service. You get great follow-up data, so you can really see what patients are doing. So these patients underwent what we call multimodal screening, and they did this every 4 months. You had to be considered high risk, meaning at least a 10% lifetime risk of ovarian cancer. So BRCA, Lynch, those patients would qualify. And what they did was screen more than 4,000 women, and they found 19 cancers. 13 of those and some of these patients went on to surgery. 13 cancers out of 4,000 women were found by ultrasound. Very few of them, none were stage 1, most were stage 2. Stage 2 is better than stage 3. Okay, we're getting somewhere, but this is not yet the answer. We need more, and we need more research, and we need to get this better for our patients. And these patients were followed long enough that we were able to document that they didn't reduce one's risk of dying of ovarian cancer. This is still ongoing. They're trying to tweak it. There's other blood tests being developed, always looking for new imaging studies. One of the studies open at UW right now is looking at a new way of doing a PET MR scan to look at the gynecologic organs differently. This is very near and dear to my heart, and I think is mission critical for sure. So, screening, not the best. Chemo prevention, not surprisingly, I'm going to talk about birth control pill use to my young patients who are coming to see me with a new BRCA diagnosis. If they're not immediately trying to get pregnant, one of the best things I can do is say, take a birth control pill and stay on it. If we can keep you on this for 5 years, I'm cutting your risk in half. It doesn't mean we won't have to do something more than that, but what a great place to start in someone who might need contraception anyway. I see a hand wave. Go ahead. You took the words out of my mouth. Did everyone hear that? What about the risk of breast cancer? Great question. Gynecologic cancers are more important. No, I'm kidding. No, that's not what I tell patients. So when the best ages to be on oral contraceptives are in your 20s. That is the most bang for your buck from an ovarian cancer risk reduction standpoint. And young women on birth control pills, that has never been shown to increase breast cancer risk. What we're starting to see is women, and the data's not great. The data that this prevents ovarian cancer is great, like top tier, excellent data. The breast cancer stuff is tough because it's so confounded with all the other things that people do over a lifetime, right? All the other environmental factors. But what we're starting to tease out is I think that long-term OCP use in your 30s and early 40s is a little bit more troubling from a breast cancer risk perspective. So what I try and do is when I find my BRCA patients early, I get them on their birth control in their 20s. By the time they're 30, they can come off of it. The breast medical oncologists don't get mad at me. And then we use a different type of contraception. But for that to work, that means their parents have to have been tested, right? Like we have to know that they're at risk when they're in their 20s. Who's seeing a doctor in their 20s, right? So you actually have to funnel these women and try and get them diagnosed, not so young that you're scaring them, but young enough that you can really do what's important. Go ahead. Mm-hmm. That's completely correct. Let's break that down a little bit. That's a great point. So what was just asked is if using birth control pills was more related to estrogen, progesterone receptor positive breast cancer rather than BRCA-related breast cancers. So some BRCA-related breast cancers are estrogen receptor positive and progesterone receptor positive. So you have to assume there's some overlap in that risk. But you're right, many breast cancers that BRCA patients get have none of those receptors, have 0 estrogen receptors. So OCP use isn't going to put you at higher risk. So something you can do in those families with a truly scary breast cancer pedigree is if you can get the details, see if there's a lot of estrogen receptor positive cancer in the family or not, and maybe tighter your risk based on that. I think you're right that people are not talking about this enough. So there's other things that are being studied for chemo prevention. Even PARP inhibitors, which we're going to talk about in a little bit, are being studied. We do know that length of time is important here, though, so that's why striking early makes a difference. This is where I could geek out and talk about my research a little bit, but we are running a little behind, so I'm just going to tell you. Oh, it's cute that they turned this into dollar signs. That's a typo. I just want to tell you that something I'm studying in my lab is something called the Warburg effect. And it turns out that cancer cells are very smart in how they use oxygen. Oxygen is something that almost every cell needs, and cancer cells definitely need. But oxygen, most cells, if oxygen's available, they're like, awesome, I'm using that. That's how I'm going to make my energy. Cancer cells do what they want. They might use the oxygen, they might not. They might make lactate acid. They have all these different energy metabolism mechanisms that they will just use at will. It's obnoxious. So something I'm trying to do is force the cancer cells to behave like normal cells, not let them flip back and forth between these two energy-producing mechanisms. And we found a medication that does that. It's called Atavacone. I think I have a picture of it. Yeah, this is what it looks like. It's a malaria drug. It's part of Malarone, if anyone's taking that for malaria prophylaxis. And what it does actually is block cytochrome. Now we're geeking out. I'll stop. It blocks something in the mitochondria that makes energy, and it forces the cells to behave better. And we know this in mice. I don't yet know this in humans. Coming soon, because it's a safe medication, so we can actually test this theory. But in mice, it actually prevents ovarian cancer development. Great. Mice are not humans. I cure cancer in mice all the time, but I'm excited. And I think this is important. I'll spare you that. I think this is really important that we're looking at other ways to prevent ovarian cancer, because the birth control pill isn't perfect. What if you want to be pregnant? That's not going to work. What about this breast cancer risk? There is something going on there. What if you have bad migraines? Estrogen's a mess for that. You can't take birth control pills. So we need more. We need more options, and I actually think that investigating that is understudied and super, super important for our ladies at risk. Right now, in terms of taking out ovaries, what the NCCN recommends for BRCA 1 and 2 patients is removing, so these are the fancy words, salpingo-oophorectomy. That means removing your ovaries and fallopian tubes between 35 and 40. Obviously, the goal is once childbearing is complete also. Now, I didn't have a kid at 35. My kid came later. So I very much recognize this is a big deal to many women, and that is not necessarily what their reproductive timeline looks like. BRCA 2, because they get their cancers later, as I mentioned earlier, right now the guidelines are between 40 and 45 for ovarian removal. This last bullet point should probably be in capital letters. This is a big discussion point, and that's tubal removal only. So we do know, and we've learned, that a lot of ovarian cancers actually start in the fallopian tube, probably more than half of them. And in BRCA patients, it's probably even more than half. The tube seems to be kind of ground zero for this. So there is some research being done, and I think we'll know this answer in probably about 5 years, that taking out the tubes might be sufficient to reduce ovarian cancer risk. We do not know that yet. And it's still very much the recommendation that ovaries come out. Now, if you come into my office and you're 30 and you said, I have my 3 kids, I'm good, please give me a permanent method of sterilization, I will happily take out your tubes, BRCA patient. That is a great idea. If you are done, your tubes, they do not make estrogen. They have nothing to do with menopause. They have to do with your egg finding its way from the ovary to the uterus. Very important for pregnancy, not really important, frankly, for anything else. So taking out tubes is a reasonable stepwise approach, knowing that right now the data says your ovaries need to come out. We still see cancer that starts in the ovaries. We still see the ovaries and fallopian tubes are touching. So the cellular milieu between those two things is very much shared. And I don't think we can expect the tubes, removing them, to solve all of these problems. So we know that this works. Not surprisingly, if you take out the ovaries and tubes, this is a very effective mechanism to prevent these cancers. Now, it doesn't prevent it perfectly, because we actually find some cancers at the time of this surgery. And that can even be a microscopic cancer. So that's very important to note. And it's also possible to get something called a peritoneal cancer later. This is terrible. So you take out the ovaries and tubes, you've done everything right, and then the patient actually gets a cancer that looks and behaves like ovarian cancer, but starts in the abdominal lining, peritoneum. It is very rare, even in BRCA patients, 1%. But it is reported in patients who their ovaries are gone and removed correctly and everything was done, they still get these, they look the same under the microscope, they behave the same, they're treated the same, they get these peritoneal cancers. So you do have to tell your patients that, because I cannot make this risk zero, and that's why chemoprevention has to be part of the game too. So, something else I gotta mention, getting the ovaries out for BRCA ladies is important for breast cancer reduction risk. Now that's only gonna work for estrogen receptor positive breast cancers. It's not gonna reduce all breast cancer risk, but it can reduce some. So in a patient who's not thinking about mastectomy or has a truly terrible breast cancer pedigree in her family, ovarian removal may actually be done also to reduce breast cancer risk. So that is something to consider. Hysterectomy just means removal of the uterus. I think that word gets used to mean a whole lot of different things, but in my world, it's just when the uterus comes out. Not really a requirement, but you might remember I said there's a slightly higher uterine cancer risk in BRCA1 patients. So I talk to my patients about that, do some shared decision making and make it good decisions. But there's no like absolute must come out rule to this. So for Lynch syndrome, not surprisingly, pretty similar, except the uterus is mandated. And remember, increased risk of uterine cancer is a big one there, ovaries too. So they're really recommending that between 40 and 45. All right, so I am gonna pause for a second. I do think a really important part of this is to recognize what we're doing to women when we take their ovaries out early. And I think it's really important to talk about some of the things we can do to keep those women well. It is 6:50 and I had planned to stop the talk about this time to make sure there was plenty of time for questions. So in the interest of democracy, we could choose. I can talk a little bit more about menopausal symptoms, hot flashes, what we do, or we can focus on questions right now. And I'm super up for either one of those things. So if I could get a show of hands for hot flashes. Okay. That was definitely more than half. Okay. So vasomotor symptoms are what hot flashes are. And in women who have their ovaries out before menopause, obviously if you've gone through menopause already and your ovaries come out, you should be good. Just to be clear, some women tell me that they have like a little resurgence, but it's usually very short-lived and it's okay and we get through it. And also anesthesia causes hot flashes for some women, so that can be confusing. But for women where I take out their ovaries before menopause, this is super common. Hot flashes, and they can be miserable. This is sweating. This is, I want to change my shirt at work. This is put my head in the freezer. This is, I'm giving a talk like this, my face is red, and I feel very self-conscious about how I look. It can also cause pretty significant sleep disturbance. If you're waking up multiple times per night and your pajamas are soaked and you have to change your sheet or your pillowcase, that's a big deal. You're not going to be sleeping well and doing that. They do go away. So very few women will have them more than 10 years. But if you tell a 35-year-old, hey, you're only going to have this for 10 years, I mean, they are not going to be very happy with your preoperative counseling, nor should they be. The first 2 years are the worst. We do have to find a way, if I am the person doing this to a patient, if I am making a 35-year-old menopausal, I believe it is 100% my responsibility to talk to them about this ahead of time and then help them afterward. And if patients are not getting that from their provider, I would encourage a more multidisciplinary approach, because this to me is, it's unethical to just leave people with these symptoms and not talk about it and not help them. So I mentioned sleep disruption. This is also a big deal. Urogenital is a very nice way of saying your vagina doesn't feel good. And that can also be urinary issues, incontinence. The vagina is very estrogen dependent. So losing estrogen, particularly losing it suddenly, can be quite traumatic. This can be a big deal from a sexual health standpoint. If you're not talking to your patients about that ahead of time, I think that's a tremendous oversight. And in patients with a history of any type of mood disturbance, anxiety, depression, this can be a very vulnerable time for them. So all of those things should be part of the discussion, along with cardiac health, bone health, all the other things that need to happen. Here's another thing that no one will tell you, but it's totally true, is it's okay to use hormone replacement after you've taken out a 35-year-old ovaries or 40-year-olds or anyone who's symptomatic. You just have to be smart and talk to them. Do you have a breast cancer history? Let's look at that breast cancer. Did it have estrogen receptors? Let's talk to your breast medical oncologist. Let's see what your recurrence risk was. Let's see if your nodes were positive. And if your recurrence risk is really high and you have an estrogen receptor positive cancer, guess what? We're going to figure out another plan. And we'll figure that out together. But in many women, they're just told no hormone ever. And when you actually dig down into their personal history and situation, it's pretty darn safe. And the key is short term, right? No one should be on this for long. And figuring out a taper and being smart about how it's prescribed using the lowest dose needed. But this can be the difference for these women in being able to work and function versus being completely miserable. And that is a big deal that should not be taken lightly. We know that if you're premenopausal and one of your goals was to reduce your breast cancer risk, that if we replace hormone at a sub-physiologic level, because guess what, you're never giving back as much estrogen as the ovaries made. That's not how HRT works, and you don't need it at that level to reduce these symptoms. So you're not negating that breast cancer risk reduction. And of course, you're going to reconsider their prior breast cancer risk history. But a lot of my patients, when I take out their ovaries, they've already had a mastectomy. Maybe a prophylactic one. So their breast tissue is gone. We still have some native tissue that's kind of in the axilla that you can't quite get rid of. But truly, they've already reduced their breast cancer risk tremendously. 6 months of estrogen, it's okay. It's going to be okay. Okay. So I will say this. When you get into the breast cancer and hormone replacement data, which is different from oral contraceptives, okay? So just to be clear, this is hormone replacement, meaning your ovaries are out. You're not trying to prevent pregnancy, you're trying to replace estrogen. The data on breast cancer and HRT, the two big studies that really told us that was a terrible idea, were all in postmenopausal women. And some of us in the room are old enough to remember that in the 90s, this was very trendy. Like my mom was on HRT, she would kill me for telling you this. My mom was on HRT for like a decade. And for no reason, she had no symptoms, no problems. Her doctor was like, yeah, you're in menopause, let's put you on hormones. That was just like what you did. And then they learned that that was actually a great way to increase breast cancer risk. But you should not compare giving hormone replacement to a 55-year-old for 10 years to giving it to a 35-year-old for 1 year. That is apples and oranges. So if someone is throwing this data around saying this is why we don't think hormone replacement is safe, it's just not fair. And there is actually good prospective data. It only includes BRCA1 patients, but they studied these patients, ovaries out, premenopausal, gave them hormone replacement, followed them for decades. There was no higher breast cancer risk compared with other BRCA1 patients. And these were patients who maintained their breast tissue. So that's pretty high quality data. I will say this. For some reason, it's the progesterone part of HRT that seems to be the bad actor when it comes to breast cancer. Again, we're looking at the postmenopausal crowd, the older crowd who got HRT, but it was the progesterone group that got more of the breast cancers. And progesterone is really important if your uterus is still in your body. So if you have a uterus and they give you a bunch of estrogen and you're supposed to be in menopause, what happens is your uterine lining will start to respond to that and divide and divide and divide, and you can actually get uterine hyperplasia or cancer over time if you're not paying attention. So if your uterus is in your body, you get hormone replacement that has both estrogen to relieve your hot flashes and progesterone to keep your uterus calm. So in some patients who I know I'm going to put on hormone replacement for a while, that can be part of that nuanced discussion, hey, maybe your uterus should come out. This might simplify our hormone replacement strategy, and it may make it safer to you over the long term. So that's pretty nuanced case-by-case situation. I see some hands up. We're almost done, so that it's going to be like a free-for-all with microphones, so don't worry. I just want to mention this. There are great non-hormonal options too. I use these all the time. Low-dose SSRIs, like Effexor, have been studied for vasomotor symptoms. You're not using them at the same dose that you use for depression or anxiety, but they do seem to control the vasomotor part of our brainstem, so those blood vessels don't get that trigger to dilate. They can work very, very well. Gabapentin can work well. These are prescription medications, and these are over the counter. Black cohosh is over the counter, 40 milligrams twice a day. It's been studied. It can work very well for hot flashes. Vitamin E capsules can work for some of the vaginal atrophy and vaginal thinning symptoms without using estrogen. So you can actually place a vitamin E capsule vaginally and smush it. Do that once a week. It's actually quite effective. So I'm not saying this because I expect you all to remember this when you go into menopause. Some of you are very young. I say this because please remember, if you're like, hey, I'm not using estrogen, Barroilhet, I'm going to say, okay, this is what I got. Like there's other stuff to do. So also don't think that HRT is the holy grail of treating all menopausal symptoms. There's other stuff out there. I think, I gotta say something about your bones. Be careful with your bones. And then we're gonna stop. We're gonna stop right there. We have to look at the cancer. All right, there were a lot of hands, so let's take a minute. I think a little fairy with a microphone is gonna appear. That's Jackie. And let's do some questions.
So if you don't mind terribly bringing your question to the microphone, so that our online viewers can hear that. I know your question is really amazing. We don't want anybody to miss out. I was trying to pull this, but also no one from dies. That seems really important in this experience.
I totally encourage the microphone. I also understand there might be questions that wouldn't feel good to ask. I am going to hang around after this too. So if there's something you'd like to ask at a lower volume, that is going to be an option.
Step right up. If anyone's shy, we have some from online that I'll ask.
Okay.
So I'm a little confused because BRCA1 is a risk factor in itself for ovarian cancer.
Yes.
So you remove the ovaries.
Yes.
So you have higher risk for breast cancer, and then you're giving them estrogen.
Yeah.
It doesn't do anything to the risk, double the risk, any change in the risk to the breast cancer?
I'm going to repeat the question just to make sure everyone heard it because this is very important. The question is, hey, BRCA women, high risk of ovarian cancer. Now the ovaries are out. We've solved that problem. We know there's still a high risk of breast cancer. How can you give hormone replacement? So you're right. I never speak in the this is how you treat a patient all the time, right? You look at that person, that specific person. Did they have a mastectomy already? Many of my patients have, right? That breast cancer risk profile is super different. Have they already had a breast cancer that was triple negative, meaning no estrogen receptors? That risk factor profile is super different. Do we review their family history and there's tons of ovarian cancer in their family and no breast cancer? That risk profile is different. So you really do have to look at that person and make a decision. What makes me nervous is I think there's been a lot of no hormone ever, and it's like being shouted from the mountaintops. And I just want to bring to the table some hormone, maybe, okay? So people feel empowered to ask those questions as they're considering these surgeries. Because I think we've made some blanket statements that have harmed certain patients. That's a great question. Thank you for asking it.
So I'm just asking about like ovarian cancer in your 30s.
Yeah.
And then nothing for 30 years. I had ovarian cancer
Yeah.
when I was in my 30s,
Yeah.
and I got recommended to have that procedure. But I was kind of scared to lose my ovary.
Yeah.
And I'm just wondering, should I be starting with the procedure or should I be starting with genetic counseling and testing?
That's a great question. So I would need to, and I certainly am not asking you to do this in a microphone.
No.
I need to know a little bit more about your diagnosis to make a great recommendation. If you're telling me that you had an ovarian cancer diagnosis, I personally would start with a genetic counselor if that hasn't happened yet.
Okay.
Did everyone hear that question? I'm sorry. It was a good question about a personal ovarian cancer history and other options from there. I think starting with a genetic counselor is great. I love that you're doing so well. That is awesome. I think that information might be really meaningful to you.
Okay.
And then obviously, if next steps are warranted, taking it from there.
Yeah, is there any service that you could recommend? You said you didn't like 23andMe, but is there any
Yeah.
other genetic testing that you could recommend?
Yeah, so at-home genetic testing in general is not as complete, not surprisingly, as some of the things that are offered through a laboratory. My favorite lab that does offer, and again, I have no skin in this game. I have no financial ties to them. Color Genomics has a very good website. They do kits at home. They do offer genetic counseling remotely, which I think is helpful. And I think they're a little bit more upfront about their limitations. So Color Genomics, C-O-L-O-R, Genomics. That would be a very Googleable thing. And they have a nice website, and I think that's a good one to start with. I do think starting with your physician or provider is good too, to review your family history. That's never a bad idea, even if you do testing independently.
Because get this closer, because there's ongoing research and you're finding more about genes, is there some recommendation over what period of time to retest for
Yes.
genetic?
This is an amazing question. So I'm going to repeat it. Yes. So the question was, hey, maybe I had genetic testing 5 years, 10 years ago. Should I have it again? The short answer is yes, probably. So what I personally would do is reach out to the counselor or the person who ordered your testing. And that can be a phone call, a MyChart, however is easy, or your doctor, and just say, hey, just want to check in. You can imagine what's happened, right? We have this whole pool of patients, and actually what we're starting to do is send them letters being like, hey, we noticed you were just tested for BRCA. Guess what? There's 10 more genes. If you would like, we would be happy to meet with you and talk about testing. So we are starting to try and reach out to patients, but we also, this is a lot of people. Bullet point 1. Bullet point 2, we're trying to reach out to the patients who are most likely to benefit. So really trying to look at the earliest testers, which would kind of be the 2008 to 2012 crowd, where we really were just testing for BRCA 1 and 2. We didn't even know about anything else I just mentioned. Then the next phase will kind of be the 2012 to 2015 crowd. In Madison at the Cancer Center, after 2015, pretty much everyone with an ovarian cancer diagnosis got panel testing. There may be exceptions, but in general, they got a whole swath of genes tested for, including everything I listed there. So if you were 2015 and on, it's always fine to ask your doctor, hey, do I need to revisit this? But in general, if you were tested in our community, it was a big swath. Earlier testing, you may want to revisit that.
I was just wondering if you know if insurance generally covers genetic testing, because my nephew who has autism had a bunch of genetic testing and they had to pay for it out of pocket.
Yeah.
And so
the only good thing about cancer that I can think of is insurance companies, once they see that word, somehow they behave better in many instances, and genetic testing is one example of that. So I'm sure there's an exception. But in my experience, almost all private insurers will pay for genetic testing. Genetic counseling is not always the case. So sometimes they'll pay for the testing, but for some reason they don't want you to meet with the counselor. And Medicare in particular is tricky with that. We are very creative at finding ways around it, but it is important with any of this, right, to make sure your insurance covers it. The good news is genetic testing has become so much less expensive because this technology has become so much better. So there are many programs where if a private insurance won't cover it, they'll agree to, the company will run your panel for $100 out of pocket or $150. I'm not saying that's nothing, but certainly for many patients is tenable. So we try and explore creative options. In general, autism, the non-cancer diagnosis, genetic testing, it's like the Wild West. Some insurance companies pay for it, some will not. It's much harder. In general, for cancer, because it can affect treatment options, you can make a really powerful argument to get it paid for. Great question.
So we got a question from our online audience that if we jump back to the question before this really, really great one about retesting, if it's been a long time since your test. So we got a question from Carrie. Could you address if you have an inconclusive genetic test or a negative genetic result, but you have a first-degree relative with fallopian or ovarian cancer, what screening or treatment might be indicated for that?
So that's a very specific question. So if you personally had genetic testing that was inconclusive but have a family member affected, would that change your risk profile, and should there be other screening? So the first thing, in a perfect world, right, the person with the cancer gets tested. Now there's many reasons that might not happen, but if you can understand if that person carries the gene and then you too carry the gene, if it's inconclusive, right, that's much more concerning, because you had someone carrying that same thing who we knew had a cancer who you share half your DNA with. And I certainly don't want to put this online person on the spot, but if your parent was tested and was negative, and then you have something inconclusive, I would say you're all good based on what I'm hearing. But if you're sharing the same inconclusive, so what this really means is there's a very common thing to get back in genetic testing, and this could be a whole other talk, is something called a VUS, a variant of undetermined significance. Great, thanks for that useless piece of information, right? But what's saying is, hey, this is on a gene we know causes problems. So an example would be a BRCA1 mutation VUS. So what they're saying is there is something on this gene that is not normal, but we have not ever seen this abnormality linked to increased cancer risk. So you can tell the story is going to play out one of two ways. More people are going to get tested. They're going to see that variant more, and they're going to see that's linked to cancer or not. And in 5 or 10 years, we'll have the answer. Today, for that person, it's not helpful. So what you would do then is go back, if you can go back to a affected individual and see if they carried that same variant of undetermined significance, that makes it more significant, right? If you know that that was associated with a cancer. But I would have to know more to really counsel that specific instance. Those are great questions that they should absolutely bring up with their physician. They're good, they're thinking smart.
So this is kind of general, but you talked about a dance that you do of trying to keep the ovaries in long enough, but get them out early enough. I was curious if you could elaborate on like what other questions or things do you take into consideration when doing that dance? Such a good question. Generally speaking.
So things that I think about are, one, if their childbearing wishes have been completed, because I think it's really important. It is no fun to know that you have an 80% chance of getting breast cancer and a 60% chance of getting ovarian cancer. This is tough. It's empowering to have this knowledge, and I think you can take some powerful action when you know it. It is also a huge weight to carry. And it's hard to watch people make big life decisions based on this abnormal protein. This blip in their DNA is suddenly controlling their life. So that's one thing to think about. Obviously, what they've done with their breast tissue. So if they've already maximized their breast cancer risk reduction, meaning a mastectomy, keeping the ovaries in a little bit longer may be safe. If they've chosen, if there's someone who's been on oral contraceptives for a big chunk of time, they've already done some pretty significant risk reduction. And then looking at other things in their family, like when did their mom or their sisters or their cousins go through menopause? Menopause is actually quite familial in terms of timing. So if your mom went through menopause at age 55, it's probably about when you'll go through it. So if they have a history of women in their family going through menopause in their mid-40s, I'll be like, listen, 40-year-old with BRCA, it's coming for you. Like, this is happening, let's do this. And if someone's like, listen, women really do this later, and I know there's not a great blood test for menopause, by the way, to let you know how close you are to it. So you're trying to really think about like how much estrogen does this person have ahead of them, and can I squeak this out? But the reality is, if you're 40 with a BRCA1 mutation, my recommendation is your ovaries come out. If you're 45 with a BRCA2 mutation, my recommendation is your ovaries come out. The dance happens in that 38 to 40 range or the 43 to 45 range, right? I can't go against what these very large committees who have poured through all the evidence and spent hours and hours making these recommendations. I'm not going to be like, I know more than you. I don't. So that's the dance.
Another online question. I think this is maybe approaching the dance a little bit. So if you're younger, so we have a listener who shared that her daughters are 19 and 20 with BRCA1 diagnosis. For their continuing medical care, should they be seeing an internal medicine physician? Should they be going straight to a gynecologic oncologist or an OBGYN? How do you recommend they manage?
So a great resource, if they happen to be here in Madison at the Cancer Center, we have a Hereditary Cancer Risk Clinic, and we see many, many young BRCA patients in that clinic. It's housed in the breast center, not surprisingly, because breast cancer is obviously a big risk for these women. But it's nice because it's multidisciplinary. So I go to that clinic. So there's a gynecologist there. There's breast medical oncologist there as well who can talk about chemoprevention options. The mammograms and MRIs happen in that same area. So you can do it in conjunction with their imaging. So I actually think at least an initial consultation at a clinic like that. And if they're in another big city or near another urban area, there may be other options. I can only speak to what's offered here. But I think that's very helpful because then we have some longitudinal care that's set up. You'll still they will need a primary care doctor, right? Like someone still needs to check your cholesterol. But it's nice to have someone who's in a cancer space who's looking out for you. Because the piece that can be tricky is right now we kind of know what to do. We have our MRI, mammogram. You're probably going to start some ovarian ultrasounds. We'll offer you research studies when applicable. Like we can map that out for you. But these recommendations change all the time. And in smaller communities, they just may not have the bandwidth to be like, oh, ATM, that ovarian cancer risk is now 15%. So the age for ovarian removal is now 40 instead of 45. Unless it's what you're doing all day, you cannot keep up with all of that. So I think being in a specialized center, at least hooked in, so you can come back to that home base is really important. You guys are asking the best questions I've ever gotten from this talk, by the way. Like very, very good questions.
What about that same question for Lynch syndrome? With my family, it's like everybody. Pretty
So-
much. We skip the 50% genetic pass down.
So what specifically? The dance?
No, more like when you start, if the younger generation are, you know, in the 18 or whatever, 23, when do they start seeing?
So in general, for colon cancer in particular, for Lynch patients, that is the cancer that tends to show up early. So what I would recommend from a colon cancer screening standpoint is starting 10 years from the earlier colon cancer diagnosis or 25. So they should definitely be hooked up with at least GI by then. From a gyne cancer standpoint, it's very rare to see cancers in your 20s or 30s. Obviously, if there is a very young gynecologic cancer in the family, they should push the screening earlier. But in general, that 30 to 35 mark is safe because it's not Lynch, and they do a lot of terrible things, but they don't tend to get very, very young ovarian cancers or uterine cancers. It's usually 40s is when things start to happen. That's a great question.
Would it be the same for breast cancer, 30-35?
So for Lynch syndrome was the specific question, and Lynch cancer patients actually don't have an increased risk of breast cancer.
For BRCA1?
So for BRCA1 right now, it's mammograms would start at age 25 for most patients. Now again, if there was a very young, with breast cancer, you can see some very young breast cancers. You'll see women in their 20s. So if there's a history of someone that young, they'll even push those MRIs earlier. So part of this, you can see, right, I'm giving you some generalities, but you have to be talking to the patient about what they've experienced in their family to the extent that they know. Because all of this, everything I've just said can go out the window. If you tell me there's an ovarian cancer in a 25-year-old, guess what we're going to do? We're going to push a lot of these recommendations back earlier, right? That's just common sense.
So you say that daughters get menopause about the same time as their moms. Do they get ovarian cancer about the same time as mom? Is there any kind of...
Not necessarily.
No?
Not necessarily. If there's a pattern, so it's hard to do it with one cancer. So the question was, if menopause happens around the same time, does ovarian cancer happen at around the same time? If you have a number of incident cancers in a family, you can look at ages and make some guesses, but really with one person, you just need some more data points. I wish I could tell you that. That would be great information to have, because then you'd really know when to take the ovaries out, right? Yeah.
When you were talking about Lynch and ovaries, you said that the NIH and the NCCN started with some screening tools.
Yeah.
But then you went to say that there were no studies.
Yeah.
So in this era of clinical-based medicine, it's hard to understand how these institutions are going to tell you to do that if you don't have any base.
So the question was regarding screening for gyne cancers in Lynch patients. So there's two pieces to that coin. The uterine cancer piece, you can actually screen for uterine cancer. So let me clarify that. That's a great question. Uterine cancer screening actually works because you can biopsy the uterus. That's a great way to screen for anything, right? Get a tissue sample. So that actually works. You can prevent or detect uterine cancer early by doing an endometrial biopsy in Lynch patients every 1 to 2 years. That works. So forgive me for not clarifying that. The ovarian cancer screening is the same muddy mess for Lynch patients as well. We do it because it's the best we have. And I do think it helps keep women engaged and involved in gynecologic care. And it's hard to quantify the benefit to that, but I do think that is real. And when you do catch something early, even though it's not very often at all, it does feel very good to do that. So yes, great question. Yeah, of course.
So in your practice, have you seen a patient with ovarian cancer progressed into the peritoneal cancer?
So the question is, have I seen ovarian cancer progress into peritoneal cancer? So I think what you're asking is, does ovarian cancer spread to the peritoneum? Absolutely. So ovarian cancer is a good crusader in the abdominal cavity.
No, I mean in your
GI.
practice, have you seen any such patient where
the ovaries were taken out and then they got peritoneal cancer? I have seen that happen.
And what is the outcome, like the prognosis and all?
Yeah, so
even after the therapy, chemotherapy and surgery and clinical trial drug.
Yeah, so it's really hard to say a specific prognosis. Again, and if you're speaking about someone you love, you do not feel like you have to answer this in the microphone. You can come speak to me. But you need to know the stage of the cancer, what kind of chemotherapy they got, how long they were treated for. I could give you some really good prognostic ideas, but I'd have to actually know a little bit more. In general, peritoneal cancer, if you get it after your ovaries are out, it is treatable. It's a big surgery. It's chemotherapy. It's all the things that happen with ovarian cancer patients. But we all know, and I know because some of them are sitting in this room, ovarian cancer can be cured. Peritoneal cancer can be cured. So that is my answer, but I need to know more to really give you a great number.
Okay, I don't think this is work. The mic's not on. Okay, so my mother had breast cancer when I was a child, so she was in her early 30s, and her mother died of ovarian cancer, and we're also Ashkenazi. So my mother just recently, we decided to have her tested, and she tested negative for the two. So how does that, as our daughters, us girls in the family, do you still recommend intensive testing?
Now we're in the land, and this is, again, guys, this is a great question. So we're talking about a patient with strong family history of both breast and ovarian cancer, and a person with cancer who's tested negative. And what do you do in that setting? That is an amazing question, very nuanced, unsurprisingly. What I typically say, though, there are genes we don't know about. That is just the truth. If there's anything you've heard from me today, is that this field is exploding. So I do say if you have a first-degree relative affected by ovarian cancer, that even in the absence of a genetic mutation, it's worth having a conversation about your personal risk. And it is probably a bit elevated from that of the general population. What I tend to do in patients with a negative genetic testing in an affected individual, but still have some very concerning family history features, is talk about ovarian removal closer to menopause, so that 45 to 50 range. It depends on the time of day. I'm not making a recommendation for you.
No, that's okay. I want to hear
But that is a common scenario, right? You have a family history that's scary. You have some good genetic testing that was done that was normal. So the universe is trying to tell me there's nothing going on. But we know there's genes we haven't figured out yet. Okay. So now you really have to just do a cost benefit with that patient. Like, hey, your risk might be higher than that of the general population. I can't quantify it in the absence of a known mutation. Okay. We know ovaries are good for you. Let's talk. Let's find that halfway.
All right, thank you.
Yeah. Great questions. You guys are rocking this. Of course you can.
So in my case, the concern I have is that my daughter's paternal grandmother had ovarian cancer, and lots of her sisters had breast cancer.
Okay.
But we don't know too much detailed histories. A lot of them have died, and we don't have too much contact with them.
Okay.
So now the question is, at what stage should my daughter be tested? What stage should be counseled, get genetic counseling, and so on?
So the question is, what do you do when you have kind of these more distant relatives? So in this case, the example was paternal grandmother and then some siblings of that grandmother with cancer. It sounded like an ovarian cancer and some other cancers. Yes. So the best thing to do, if you can, is test the dad. So her dad passed away. I'm so sorry. So that would be one solution. I'm sorry that's not an option. And I'm guessing the paternal grandmother is...
She's an only child.
She's an only child.
And the dad, we cannot test. Don't know much else.
How old is your daughter?
She's 16.
Yeah, so I almost never met it for these disorders. There's many other things. For BRCA, I almost never recommend testing before 18. So I would say wait till she's an adult and she can make a decision. You can talk to her about what this might mean for her. And you know what? You can meet with a genetic counselor and not get testing. A lot of my patients do that. So I would suggest you could go with her to that visit when she's 18 if she would like to go, and just talk about it. Talk about what it looks like if it's positive, what it looks like if it's negative. She may say, hey, that would be great to know when I'm 25 or 30, but I'm not ready to know yet, and that would be super reasonable. If you don't have a generation back to test, and there's no one, and did your husband or her father have siblings?
Yes, brothers.
Any cancers there?
No.
Okay.
Not in the brothers, but one of these
Yeah. Yeah, you are, I mean, it's getting a little more removed, so that's good. Like, there's not like those first-degree relatives.
Is there a sense of high risk here, though?
I can't, I mean,
It's not in the.
it's so hard to
first
know.
degree, but so many.
It's great that there's no first degrees, but it's true. I mean, grandmother is direct lineage, right? Like that is a method that a gene can be directly passed down. So without knowing more details, I never think it's wrong to meet with a genetic counselor. They'll go over this. They'll help you get as much family history as possible. It won't harm her. She doesn't have to get tested, right? So that would be her choice when she's autonomous and older. Yeah. All right. I think we should shut it down. I will stand here, though, and I will answer any questions, but I'm going to turn off this microphone. Webinar people, signing off. Yes. Thank you for your attention.
Thank you, Dr. Barroilhet.
Yeah. Oh, my gosh. Happy to be here.